And g'day, welcome back once again to the BroomeDocs and the First 10 and EM Journal Club podcast. It has been a little while. We have been on vacation. We've been busy young men, and it's been a little bit, but I think we're picking up exactly where we left off. How does that sound,
I think
Justin?
you're stretching a lot of things there, especially the young men aspect of it. But yeah, I the expectation should be high. We're rested. We should come in better than ever. I don't know what that means, though. The bar has never been set that high, so we'll see how it goes. I definitely took the months to sneak in some odd inclusions this month. So we'll see how you critique me for some of the papers that I threw in here that are a little out there. That's all right. I think we can jump back in and hit our usual standard of quality.
Yeah, it's 9 papers, I think, this month, and it is incredibly eclectic mix. There's stuff from bench science to stuff that you wouldn't read about. So some of these, I don't even know where you find them because they're not in journals that I would think any self-respecting emergency physician would be reading. But hey,
self-respect. Is that something I'm supposed to have? Is that the problem? Yeah.
You're so Canadian. So just before we get started, the reason that Justin and I have been off the airwaves for a few months, we've both been very busy. It's conference season starting up here in Australia, and I just wanted to throw out a quick plug for a couple of events that are coming up. There's a big conference coming up in Broome in exactly 1 month from today, actually. We're recording this, so this is starts at the start of October. And one of my favourite Canadians will be attending the conference in person. Yeah. You know who that is, don't you, Justin?
Ken is everybody's favourite Canadian,
yeah. Oh, I'm not sure about that.
Since John Candy passed it a number of years ago, he was a pretty good one. But,
are you guys still claiming Bieber? Yeah. I don't know.
No, not if I have anything to do with it. Him and Celine Dion, they can move to the States and stay there forever.
Well, we're going to get hate mail. Thank you very much.
2 people listen to our podcast. We just lost one of them. Yeah.
Although, if you can find someone that's offended by Celine Dion and Justin Bieber in the same demographic, you're doing very well. So, awesome. So we got the conference coming up in Broome, and Justin, you'll be making a virtual appearance there along with Ken. Scott Weingart's going to be popping his head in for an hour or so to tell us how to do things better in rural emergency departments. So it's going to be a really fun conference.
That sounds amazing. I will. I'm looking forward to being there. Just sad that it'll be in this format. I'll have to try to get my microphone fixed before then and not have to hold it brokenly in my hand.
It looks kind of cool. It's kind of gangster.
If I could just spit some beats or whatever they call it, then it'd be a lot better. I just don't have that skill in me.
Right.
Before I say anything,
jump into some papers before people get
it's a morning
really
here.
bored.
I'm not even the one drinking. I shouldn't be causing problems for us.
Cool. All right, let's go. First paper, one of my pet peeves, one of my hot topics that really gets me going in the mornings, and this is a randomized controlled trial out of Switzerland, which was looking at kids with strep throat. So one of the commonest presentations that we see to the emergency department, and they were randomized to receive either amoxicillin BD for 6 days or placebo. And this trial, with such a common presentation, you'd think they'd get, 2,000, 3,000 kids into this trial? How many kids did they get into the trial? 88. And there's a lot of reasons why this didn't happen. It was during COVID times. So we're still seeing a few trials that were horribly affected by COVID, unfortunately. But a lot of these kids' parents just didn't want them to be randomized, which is quite interesting in such a benign condition, which is very common. So anyway, this was your favorite design of trial. I'm being sarcastic for the new listeners. The non-inferiority trial, which usually gets Justin's blood pressure very high. And what did they find, Justin?
I think this is going to be a really good example of why non-inferiority trials are stupid. And unfortunately, this trial was probably poorly designed from the beginning, even though it's, we like randomized controlled trials. the big problem. So non-inferiority trials have this odd statistics thing where it's all based around the size of your confidence interval. And so the bigger the confidence interval, the more likely it is going to be hitting this threshold. And the researchers just get to make this up. There's no scientific method, but however, whatever the threshold is that they decide something is non-inferior. But that just means that if you make a trial smaller, the confidence intervals get bigger, and so nothing is ever non-inferior. And if you stop a trial early, you can't run the trial anymore. Like the stats just don't work. And so here they stopped it early, or they didn't reach their enrollment, which means they automatically have bigger confidence intervals than they were expecting. And so when they say it's not non-inferior, it's just stupid. It doesn't make any sense. They should have just not run the statistics, because that's just not how it works. So they say it's not non-inferior, but anyone looking at these numbers, they're basically the same. There might be a difference of as much as 6 hours of fever between the two groups, but it's sort of like, who cares? I think it was 21.7 hours of fever with amoxicillin and 24 hours with placebo. That's not different clinically. And so who cares what the stats are? There were a couple other things. There was no difference in like the overall symptoms, the pain or anything like that. There was no difference in paracetamol or NSAID use. And so who cares? But the bigger problem to me is the design at the beginning. We've had a number of these trials. I don't think there's a single physician out there that has any question in their head about whether antibiotics make an impact in symptoms. Yeah, they probably make like a couple hours worth of symptoms. It doesn't matter. It's not an important difference. But if you really care about a few hours, maybe antibiotics make a difference. But that's not the question. And so why are we even designing a trial around that? What we care about is, do antibiotics actually decrease all of the complications of strep throat? And that's still a bit of an open question. We know for sure there were big enough trials back in the 50s that it definitely decreases rheumatic fever by about 50%. But that really depends. Like in most places in Toronto, rheumatic fever is not a thing. We just don't care. It doesn't impact my treatment decision. Whereas when I went and worked in rural New Zealand, it was a big thing. And I know for you in certain parts of Australia, it's a big thing. That is a treatment decision. But then there's these other ones that most trials say that antibiotics don't impact retropharyngeal abscess. And that makes sense to me, because I don't know, people talk about this, but every retropharyngeal abscess I've seen has had like 12 hours of symptoms. It wasn't like there was a preceding week of sore throat that nobody treated with antibiotics and then they got a retropharyngeal abscess. No, they just came in and they had a retropharyngeal abscess. So I've never really bought it as a complication. Anyway, in this trial, they did find a pretty big difference between the groups. It was 13% treatment failures versus 5% in the placebo group. Not statistical, but like that's more than a doubling. And so that's the only outcome we care about. And it's sort of hinted at that maybe antibiotics matter. Although I have some major problems with that. Number one, 13% failure rate. Like 1 in 9 of my kids is coming back. I've not given antibiotics in 15 years for any pharyngitis. 1 in 9 of my kids is not coming back. And I think the big thing is they're including otitis media as a quote unquote complication. But like, we know that if your kid still has fever at 5 days, some doctor somewhere is going to look in their ear and decide it's a little bit red and throw antibiotics at it, even though you don't need antibiotics for otitis media anyway. And so I think that's the big problem, the fact that was included. So I do think we need a trial. I think we need a proper trial to figure out whether retropharyngeal abscess is actually influenced by antibiotic use. My guess is going to be no, but it might be influenced a little bit. But that's going to require a 1,000-person RCT minimum. I'm not sure, but that if anyone's doing research in this area, that's what we need. We don't need any more of these is sore throat or fever impacted, because that's just a dumb. It just doesn't matter. We know it probably makes us tiny different, but that's not why we would use antibiotics.
And you're going to need more than 88 kids to prove that, because some of these complications are pretty rare. Like they're sort of the 1 in 100 complications. So you're going to need a lot more kids to sort of make a meaningful difference between two groups. The other interesting thing that was in this trial was that they included kids from the age of 3 up to the age of 15. And in my world, the microbiology in those groups is very different. Like the kids at that lower end of the spectrum, most of them, sure, they may have strep. They probably go to daycare. They probably share it around with their friends. But that's not usually the cause of it. Whereas the older kids, maybe they are getting some bacterial tonsillitis, which is causing, because we know that the rate of colonization with strep in kids is probably up around 30% or something. So you don't really know if that's what's actually causing the kid's symptoms or not. So it's, although they did swab all these kids and did a rapid antigen test to show that yes, they do have strep in their throat, it's still not clear to me that that's actually the cause of the symptoms. And so our antibiotics even indicated that's one of the questions.
And it makes this whole thing very complicated, both scientifically but also clinically. But I think it hints at a misunderstanding of the whole idea of treating strep throat. Like, parents think that you're making their kid better faster. And I think a lot of clinicians still think that too. And I think maybe that's hinted at in this trial, because the whole idea, so to get into this trial, you had to have a McIsaac score of 3 or greater. That, when you look at Centaur scores or McIsaac scores, the whole concept there never made any sense to me, because the real reason, if you ask infectious disease or pediatricians why we're worried about strep, it's rheumatic fever. But if you're worried about a potentially very important, very morbid condition, you need a test or a score that is highly sensitive, not one that is specific. And so the idea of looking at this McIsaac score and trying to find higher and higher, like, you're looking for the higher groups, doesn't make any sense. If you're really worried about preventing rheumatic fever, you should be highly sensitive and just over swab, over treat, over whatever, because that's the important thing. So like we sort of have mixed up. I agree with, if you were really trying to make people feel better, then really finding the ones with bacteria makes sense. But if you're really worried about rheumatic fever, you should just swab everybody and see, but then you get these false positives from carrier rates. The whole thing becomes sort of fruitless. And I think you just have to follow base rates, essentially. When I'm in Toronto, I never test, I never treat, just not a thing. When you work in a area where there's higher than 1% rheumatic fever, like in rural New Zealand in the past, or in your neck of the woods up in Broome, then just be very liberal with it. This is one of the, who cares? You give out some amoxicillin every once in a while, right? Like, this is not that hard.
We don't swab these kids anyway because the risk is so high that we just treat. So we don't really need the swab, because the swab doesn't really help you, because you're going to treat the kid based on their demographics, essentially. The other thing that I really want to say, because I have a bit of a soapbox on this, and I've written quite a few articles on this over the years, is that we who work in the rheumatic fever areas of the world, we don't really think of it as a strep throat disease. Yeah. This is an impetigo disease. So it's kids with chronic impetigo who get this disease. So please, first world countries, stop doing tonsil studies, because it's not actually very helpful to the people that actually get this bad outcome. We're much better off looking at impetigo and the treatment and the eradication of sort of skin disease if we really want to fix these kids. So maybe we should be swabbing kids' fingers or pus sores rather than their throats, because that's where it comes from. And I completely agree. Swabbing throats, I think it's my most downloaded article I've ever put on the BroomeDocs podcast was about swabbing throats and why no one should be doing it. So cool. I think we've said enough about that one, Justin. You've disappeared from the screen, which
I'm
not
still
sure
here physically. It just sometimes the equipment
here
on this end, when you haven't had a podcast in 5 days, is rusty. It just wants to fight with you. I will put in a plug. You threw a wrench in my whole plan with the impetigo thing, but that's a very, very good point. I had held off on this for like 6 months, because I have read from the 1950s, the 1940s, like almost all of the literature, and I've been writing up one of those like in-depth reviews. And I was going to do an EM cases journal jam at some point. I don't know if I formally invited you yet, or I was waiting till I did. At some point. Yep. It'd be nice to have somebody who actually sees the rheumatic fever cases and just go through the entire world's literature. And so I think there is some complexity in terms of, like, when you look at relative risks, I think antibiotics do decrease things a little bit, but the problem is just on the face rate of the actual complications that changes everything. But at some point, I've just been way too busy. There may be a much more in-depth look at this for anybody who cares. So you can keep an eye out. We'll plug it again if we get there. But as one paper, this one is not the one to look at if you're deciding what to do about strep throat. That's all I would say there.
I'm very surprised it made it past the publishers, to be honest, because it's clearly a trial that was aborted halfway through and probably should have remained there, but that's the way it goes anyway. So, all right, let's move on to paper number 2. And this is a bit of an interesting one in that this certainly changed my perspective on resuscitation. So this is a paper by Leech et al., and this is in Resuscitation, so big journal, from February this year, and it's a retrospective sort of data dredge, mainly case reports and case series, and they only come up with I think 66 women who underwent cardiac arrest in the later phases of pregnancy, and they looked at the maternal and neonatal outcomes following a resuscitative hysterotomy, or what used to be called a perimortem C-section, but I think we're calling it a resuscitative.
Yeah, we'll talk about it at the end. I actually think maybe we need to go back to the old terminology, but let's we'll go through the data first, and we'll see.
Yeah.
No,
I don't think it really matters, but the point of this is that they've tried to identify as many cases from the literature of women who've arrested during pregnancy, the second part of pregnancy, and then had a procedure to remove the fetus, and then they've looked at what's happened to the women and what's happened to the fetus, and what we're taught when we're doing these ALS training is that the reason that we're doing this procedure is not to save the baby, but it's to, get rid of the placenta, return the maternal blood flow, and overcome the shock, so to get the woman back to life so that she can go on and live a normal life, hopefully. And that's what I've been teaching that for years. But no one's ever really told us what happens to these infants that are born as a result of resuscitative hysterotomies. And it's always been thought to be quite a dire outcome, but the statistics would suggest otherwise. Do you want to go through the bottom line? What did they find?
What I always thought was exactly the same, or at least that was a big teaching over the last decade after I got out of residency, was that stop calling it C-section specifically, because this is not about getting the baby out. It's about saving the mom's life. And it turns out in the data that they could find, at least, and I mean, they did Prospero methodology on their systematic review, although I don't know if that matters that much, as you say, 66 people from a few case series and case reports. Maternal survival was only 4.5%, but newborn survival was 10 times higher at 45%. Almost half the kids survived. And I was shocked in it initially, because that is not at all what I've been taught. Everything's all about do this because you're going to save the mom. Don't worry about the dates of the kid. Don't worry about anything. Just do this because you're going to try to save the mom, and that's the best possible thing to happen. But it only took about a minute of reflection to realize how obvious this should have been, right? You have a woman who died. You don't get people back from the dead all that often, but inside is presumably still a healthy fetus. There's nothing wrong with baby or fetus, but mom is dead. So obviously mums are going to have horrible outcomes, and babies should still have okay outcomes. I mean, you're a baby with a dead mom, unfortunately. So it's not going to be perfect, but this should have been actually pretty obvious. But the numbers did shock me. I don't know clinically what the takeaways, like, this shouldn't change anything. One, I think, clinical piece of information that I think is pretty important to get out there is, we always talk about speed, and you're supposed to start this procedure at 4 minutes. Nobody starts it at 4 minutes because everybody's freaked the hell out. I still want you to start it at 4 minutes, but I think people feel guilty, or they hit 15 minutes and they're like, well, maybe we just shouldn't do it at all. But they talk about finding a mother who had the procedure started at 29 minutes and still had survival with good neurologic outcome. And they talk about a neonate where the procedure was started 47 minutes into the arrest and still had good survival with good neurologic outcome. I do not want people to use these numbers to delay the procedure. It needs to happen early. But if you happen to find yourself, you just forgot, or things are chaotic and it's 15, 20 minutes, don't feel guilty. Cut as soon as you think about cutting. That, I think, to me, that is a pretty important thing. But then the other thing is, I never knew the just number off the top of my head. If you do this procedure and nobody survives, you still did the right thing. I think you just have to go in knowing that the outcomes here are pretty dismal. And I think most of us would know that. But there may be judgment from the room. You did a pretty dramatic thing that people are not used to, and nobody survives. You don't get to look like a hero. And I think just going in knowing that is going to be the case is reasonable. And actually, maybe I should point out these numbers, 5% and 50% ballpark, are almost certainly way higher than reality, because these are basically on case reports. And you don't write a case report on the bad outcomes, right? You can imagine maybe 10 times as many perimortem C-sections where everything went bad. People write up the cases where things went well for the most part. So just expect bad outcomes, but still do it. This is the classic, as long as you're doing this for the right reasons, which nobody's going to be doing this for fun or their own training. This is the worst of the worst. This is just something we should be ready to do and do fast.
Yeah. It's it's very similar to, the crack the chest in sort of resuscitation for traumatic arrest. Like if your intentions are honourable, to paraphrase the great Dr. John Hines, then crack on and do it. But a 45% survival rate in an infant, like if the father's in the room or the family are in the room and they're watching this, and you say, look, there's a 50-50 chance we're going to pull out a live healthy kid, like no one's going to say no to that. Like that's completely the right thing to do. So I think, that was probably the most sort of eye-opening statistic for me. And this was that I never expected that number to be that high. I always was quite dismal about the mum's survival, but I thought the kid would be similar or maybe 10%, but getting up towards 50%, as you say, we don't really know if that's a true number or not, but it's a lot higher than what I would have anticipated. A couple of other subgroup sort of things, if you can talk about subgroups in a 60-patient sort of cohort, but if there was a motor traffic accident, so traumatic cardiac arrest, there were 0 survivors. So that was quite an interesting number. And interestingly enough, the ones that were done pre-hospital, so done by paramedics in the field, they also had zero survival, whereas the patients that made it to the ED had better survival. And it doesn't really make sense when you look at the timing of it, because the pre-hospital ones you think would do better because they're getting it done earlier. But as you can see from the numbers, maybe earlier maybe having it done in the right situation by the right people is the way to go. I don't really know how to explain that.
You have to wonder in what system
say,
or where are you doing this pre-hospital? And my guess is if you had the option of doing this in a sterile environment versus on the road, the only time you would do it pre-hospital is if you were already at 20 minutes, 30 minutes. Like you're thinking it's already a little bit too late. So probably there's a time-based bias built into that. It would be my guess. And it's not the environment. It's just it's a subset of people who you would even consider doing it not in a hospital environment.
And I guess a lot of those pre-hospital ones may have been also the traumatic arrest ones as well, where there's just massive exsanguination, and so it's never going to work either way. So interesting. Certainly will change my practice and my teaching anyway around what we say, and hopefully this never comes up again in my career in the next 5 years before I retire, Justin. But if it does, I'll definitely have intentions that are honourable and crack on.
I've done infinitely more of this in simulation than I have in real life, and I would be very happy to keep it that way. But I am, I guess, mentally prepared, as prepared as anyone can be.
You carry a scalpel in your pocket.
I used to until I reached into my pocket and like really gashed up my palm one time. And now I just really make sure that the resus rooms are properly stocked, which is a harder task than it seems. The next one.
Well, this next paper, Justin, you are going to explain to me, because this is the most bizarre paper of the month from your catalogue, and I got to say, I think it's the first paper we've ever discussed from the journal Cell. Which is, it's making its debut on the podcast. And I tried to read this paper about 3 times, and I just got acronym anxiety every time I read it.
I normally when I include things, I include papers that I actually think that people should or might enjoy reading. Like that is generally the case. I'm not sure that's the case here. I tried reading this 4 or 5 times, and I got a headache every single time. I found it because of a science blog that talks about up and coming therapeutics and things like that I found, which was a little bit easier to read. And I just thought the concept was fascinating, and just thinking through sort of the future of therapeutics. I think a lot of the time it feels like we haven't made giant improvements in medicine since the 80s and aspirin for MI. And it's nice to think about people still working on the back end. I don't know that we've been very good about our form, but we lost 5 months. We forgot things. So this is Lee, serotonin transport inhibitors. Serotonin transport inhibits tumor immunity through regulating the intratumoral serotonin axis in Cell 2025. I barely got through it.
Perfect.
The basic concept is that there's a million pathways that cells need to grow and divide, and cancer obviously uses a lot of them, and serotonin is central to certain cancers' growth. And they thought, hey, we block serotonin in a lot of ways already. We have these serotonin reuptake inhibitors that are widely used. And so they tested it in some rats, as you would expect. And they saw some decreased tumor growth. And so there's some physiologic reasons to think that SSRIs might have a role in cancer, and there's some animal data. And I normally poo-poo that. Animal data, physiologic data is problematic. There's many reasons that it doesn't end up working in human trials. So it's the kind of thing that I would normally ignore. I just thought it was a little bit fascinating. And when you see all these pathways that you may not even heard of in medical school, or you haven't read about since then, it just triggers a different part of the brain that I think might be healthy for clinicians. And it made me a little bit optimistic. Although I have to say, if this was real, there's so many people on SSRIs. You think somebody would have just noted this in some kind of observational data set by now. Like the data is almost, there are enough people who have cancer who are on SSRIs. So I'm not 100% sure that this is going to end up being real. And I'm not 100% sure that it was a valuable inclusion. I just thought, if there will be a subset of our listeners who are curious about biology and reading through some of the pathways and thinking about different ways therapeutics might be used, might be beneficial. And we probably already spent too many minutes on this silly, weird inclusion.
It's a fascinating theory, and maybe we should put a link to the original sort of blog post that described the trial, because it's actually really hard to read, I found. But I did learn a few interesting things, that only 5% of the serotonin in your body is actually in your head. Like 95% of the serotonin in your body is actually in other parts, like in your gut and other parts. And it has a lot to do with inflammation, which I didn't really realize before I read this. So, it sort of makes sense. And I did have some flashbacks to third year medical school immunology, looking at all these CD4, CD8 natural killer cells and all this sort of stuff. So thank you for making me revisit that. But I'm sure that there's some young listeners out there that have to do a year of research, and it'd be a fascinating place to go.
It's the easiest trial in the world, because if you want to look retrospectively, there are well-documented patients who are on SSRIs and who are not, and you can just see what their outcomes from cancer are. This would be a pretty easy publication with a easy citation as to why. So, yeah. All right. Move on to something that I think is actually very clinically relevant from one of my favorite Australians out there. This is a paper entitled "Deliberate Clinical Inertia: A Paradoxical Strategy to Improve Patient Flow?" Unfortunately, I think you could have just ended it with a period, because I tend to agree. In your journal down there, 2025, April of this year. This is.
Yep. And are you going to do the pronunciation, or do you want me to do it?
I've emailed back and forth so much with him, and I'm sort of embarrassed that I do not know how to pronounce his name. Do you know? Yeah,
it's actually really easy. It's the same. Yeah, it's the same as Kaiser, like the king of Prussia.
Okay, that.
Yes, that's Kaiser, because that's how
I was a little bit nervous.
King.
That's good. Kaiser.
Yeah. So Gerben Kaiser, who's an amazing guy, and he's now the professor of emergency medicine over in Queensland. So does a lot of great research, and is clearly a very deep thinker about what we do for a living. So cool. Yeah, tell us all about this, because it's fascinating stuff.
Deliberate clinical inertia, he defines in the paper as the conscious process of doing nothing as a positive response to clinician and systemic intervention bias. The great Jerry Hoffman always used to say, "Don't just do something, stand there." Often, the human biology has been honed for millions of years, and homeostasis is a wonderful thing. That the body will very, very frequently just heal itself, and we get a little full of ourselves, thinking that we are the ones doing the healing a lot of the time. The idea here is that not just that is a good for our patients, but that we could potentially help our departments a great deal, help flow a great deal. That's been part of my teaching forever. Any student who wants to know how to get more efficient, how to see more patients, my number one teaching is don't take a one-touch patient and turn them into a multiple-touch patient. Little tests seem like they're nothing, but it's not just the time you take to reinterpret that chest x-ray. There's mental space knowing that you have to check the board 4 or 5 times to see if the x-ray was actually done. Sometimes the patient got lost. You got to send them over. Then you got to go find the patient. Maybe if you're in a department like mine where they don't own a bed, you got to bring them back into a bed. They went outside for a smoke. You can't find it. It takes so much time for one simple little test. And so anytime that you can deal with a patient in a single sit down visit, it's way better than ordering extra tests. And I think that makes sense. He talks
Yep.
about some issues where, you know, in the modern era, patients, I think, have more expectations from us. But he thinks that this is that we can actually enhance patient engagement and satisfaction using this practice. And I think that's true. Like I've been pressured. I'm a pretty big proponent of not testing, and I've felt the pressure to order more tests. But I think the most telling thing to me, if I really reflect on this, is you see a lot of bounce backs from other hospitals at times, patients to have an ongoing symptom 4 or 5 days later. And I hear the quote, "That doctor there did nothing for me." And I look up the chart in the electronic record, and man, they did a full workup. There was all sorts of tests ordered, and either it was a perfectly adequate workup or even a superb workup, but the patient still felt, despite all the tests ordered, like the doctor did nothing for them. And to me, that is incredibly telling. They're unsatisfied with their care despite the tests. Whereas a patient, you get that great clinician. You overhear them in the other room. They make the patient feel heard. You could order 0 tests, and as long as the patient felt heard, as long as they feel like they had your undivided attention for at least a couple minutes, they don't give a crap what you actually ordered. So I think that's a pretty important lesson to learn, and I think he's right that it will enhance patient satisfaction and throughput if we can all learn this lesson just a little bit.
Yeah, it's a really, I think, coming from the background of general practice, like this is what general practitioners do well, is they sit with patients, they chat with them. They can't do a test right away because it takes time to get these things done, so they have to send the patient away to come back. But usually patients come for reassurance, and that's what they really want. And paradoxically, tests actually undermine reassurance. Like if you think of someone that presents to the emergency department having a panic attack, every investigation you do on that person is making their anxiety worse because they are thinking that you're thinking that there's something going horribly wrong with them. Whereas if you just walk in the room and say, "You're having a panic attack, we don't need to do any tests, I know what this is, you're going to be fine," that's much more therapeutic than ordering a chest X-ray for their shortness of breath or an EKG for their sort of chest pressure. So this is just really good advice.
And he doesn't even get into it here, like efficiency. He's talking about efficiency in one visit, but you take that patient and the ordering of the test suggests that they need to come back to have the test ordered every time this happens. In fact, going back to our very first paper, the number of patients that I've had in my life who get pharyngitis 6 times a year, and they have come immediately to the hospital because every doctor ever has always swabbed them. And whether they got treated or not, they think that a swab is part of it. And I sit down and talk to them about the evidence, and they are so thankful to know that they don't have to waste a day of their life every time they get a bit of a sore throat. They can just treat it symptomatically. Like we like the number of patients that are coming back, they think they need to come back because we order tests and don't explain what we're doing. So
yeah. So a lot of that's about empowering patients as well, just to take control of their own healthcare, which, in some ways ordering all these tests because doctor knows best, and it's a bit paternalistic in a way. So it's quite interesting. In our department, when I say my department, like the big busy department I work in, not the small country department, but it's a team sport. So we have doctors at the front of the house, and then we have doctors that work in the waiting room and doctors that work on the floor and in different parts of the emergency department. And I often find myself feeling the pressure to order tests, not because I think it's indicated, but because I think someone else might think that it's indicated. And that speaks a lot to the culture of the department. And that's, as a senior clinician, you need to sort of be part of that cultural shift and saying, well, actually, no, that sort of 50-year-old bloke that fell down and bumped his head and isn't taking any medications doesn't need a CT scan. I don't care, what the Canadians CT head score says, like, this is a low risk, and I'll have a chat to the patient about it, and he can walk out the door and take some Tylenol, off he goes. Whereas I think often, especially when you're in that sort of really frontline, front of house position, which we have in many of our emergency departments now as a result of the waiting room medicine, is you end up ordering a lot of tests just in case someone else down the line wants it. And that's part of the culture, I think, that really needs to change in order to reclaim this sort of patient-centered care.
I know there's some hospitals in Canada that do that as well, but the culture where I work and around most Toronto is instead to have nursing directives that cover all that. So we don't generally have the triage doc. We just try to get you pretty quick. And I think that really fits into what he's talking about here, because there are doctors in my system who love it. They think that nurses should just be drawing blood tests on everybody. And I think it causes so many problems because the tests that are sent are never the ones that I want. But then often I get to the patient and the tests have been drawn, but they're not back yet. So now I wouldn't have sent the test in the first place, but now the patient has to wait an hour for them to come back, or I risk them leaving and then if I'm finding weirdly that their potassium's way off or some crap like that. So I actually think that we cause massive inefficiencies by trying to front load all these tests. And he mentions that he would love to see an RCT, and I think it would be a great RCT of all this front loading, just getting the tests going, which would be usual care, versus just having a senior clinician coming and assess the patient right away at the front. And I think he's right that we would be far more efficient getting the doctor to you first. The problem is just, it's really hard to do that when our systems are overloaded with patients.
Absolutely, and that's the problem. But like you said before, if patients weren't turning up to the ED expecting a CT every time they bumped their head, or a blood test every time, or a throat swab, then they wouldn't be in the ED, and we wouldn't have this problem in the first place. So we've sort of created this own rod for our back in a way by being too good in some ways. If you can think of over investigating as too good, like there's a lot of really good choosing wisely stuff. I don't know if that's a thing in America where we have this choosing wisely campaign where we try and identify really low value things that happen, like x-rays for back pain and things like that, which is really useful. And that's the sort of presentation where, you know, when you've got that evidence and you've got a guideline that allows you to minimize what needs to be done, that's really useful. And I think that's something that needs to be pushed further and further, so that as the front of house doctor in the waiting room, you can actually just walk up to someone and say, "You're fine, you can go home," and that's would make a big difference to both their day and everyone else's. So I don't know. Yeah, great paper. Definitely. I sent it to my colleagues this morning as a bit of a joke, because we're currently, I think our emergency department's been on code yellow for about a month at the moment, which means there's no beds in the hospital. So, it's very
sadly, that's just
what we're doing.
The Canadian emergency departments or hospitals have all been on the equivalent of code yellow for about a decade and a half now. It's just a funding issue. So that's just our natural state here. I'll give the quick list. I don't think any of these are going to be surprising to any of our listeners, but he does have a quick list of things that might be practice changing for some people, some things with good evidence for conservative management. You could just buddy tape boxers fractures rather than having to put a cast on. I'm not sure everybody's picked up on that one, but there's pretty good evidence for that. Obviously, his paper in the New England Journal of Medicine, conservative management for pneumothorax. I love that. Helps patients a lot. Just not putting IVs in patients off the bat who only need blood work. That's mixed, because I find the nurses I've worked with have picked it up on the wrong patient. If somebody's coming in vomiting their guts out, I'm probably going to order their medications through the IV, and often they've just drawn the blood work and not put the IV in. So you got to have a good conversation, but I do think that that's a good one. Coagulation studies essentially never change practice. Why are we sending them as part of a routine chest pain workup or whatever? Alcohol intoxication blood tests just don't matter. Just watch the patient and they will likely wake up. If they don't wake up, then you got to add that CT head and stuff. But
that's also from Gerben's part of the world as well.
And then obviously our favorite, oral versus IV antibiotics. Just pick the oral. So I think that's a nice little list, and I'm pretty sure we could expand on it. But all of those things, again, my focus when I talk about these topics is patient care. I think these are all better for patients, but it's also really nice to be faster and see more patients and be efficient in the department. I might add to that list, forget sutures. I use glue on 95% of everything that I see. And I think it's great for patient care. And nobody wants a needle. Nobody wants stitches, but also instead of taking 10 minutes, 15 minutes to do the whole procedure, I'm done in 30 seconds and I can see a whole extra patient in the time that the doctor's off doing their procedure. I think those win-wins are important things to focus on.
Yeah. It sort of feels like cutting corners, but it's actually, you're not really cutting corners. You're actually doing good medicine, and that's what's making the whole flow work better. So yeah, I think it's good for everyone if we can do this, and it would make it'd be a great thought experiment. If anyone out there is listening to this, one of my trainees, if you're listening to this, if you can expand on that list, and we'll put it up there right at the triage, and the triage nurses can identify patients with any of these problems, and we can hopefully get them seen up front. And
I think it really
expedite
needs
their
to be
care and make them
emphasized
happy.
because, some people feel like they're cutting corners, but the key in my mind to being a great emergency physician is the capacity to move very, very quickly through a lot of patients so that you have the capacity to stop, pause, and take your time on the patient that actually needs your attention. If you're going slow for everybody, you're actually doing harm to whether it's the resuscitation patient or just the complex patient that needs your full brain capacity. I think people think that they're great because they go really slow and plod through the patients, but it just hurts the department. So great emergency physicians who I know identify, walk into the room, healthy, don't need to spend my time, sick, grab the chair, sit down, and spend your time. So I actually think you are really doing your patients a service by moving as fast as you can. Moving meat is the old bad terminology, right? Meet them, treat them, and street them is the SGEM one. But we say that, it becomes a joke. But when your judgment tells you right off the bat that a patient is healthy, what you are doing is reserving your time and your mental capacity for the patients that need it. And that is an important ED skill.
Yeah, cool. Yeah. I think that's a great takeaway line.
And then I'm going to hit you with this next paper.
Should we move on to
go straight from that to I'll read it because then you can make fun of me. The name of the paper is "The Floppy Iris Syndrome: What Urologists and Ophthalmologists Need to Know" by Zaman in the Current Urology. Oh, all the way back from 2012. I don't know how this came across my desk, but I'm sure you learned something from it. I sent you this paper. Were you happy that I sent you this paper?
I was, because one of my jobs in anesthetics is anesthetizing people for eye operations, and we have a lot of people with really dodgy cataracts up in the north where they're just like these really hard cataracts, and a cataract operation is usually really quick, but sometimes they go for ages because they just can't get the bloody thing out. And I wonder if this contributes to that, because it's one of my frustrations in anesthesia is watching someone operate down a microscope and having no clue what the fuck they're doing down there. But I do like the acronym IFIS, Intraoperative Floppy Airway Syndrome, which sort of sounds like a terrorist organization with a lisp. So the idea is that if cataracts happen in old people, prosthetic problems happen in old people. So there's a lot of old guys out there walking around who are taking Tamsulotion for their prostate, which is fine. It seems to work great. But there's a cross-reactivity in that the same receptors are on the iris and on the prostate gland, smooth muscle, the alpha receptors, and this makes your prostate relax so you can pass urine more freely, but it also makes your iris relax so your pupil constricts, because your iris is actually contracting when it dilates, which is an interesting thing. And probably the most important thing I learned from this is that the ophthalmologists were complaining that if the patient is taking Tamsulosin, that they makes it harder to operate because the iris is small, and even when they put the dilating drops in preoperatively, it didn't dilate up as much as they would really like. It's quite interesting scientific technique they went through, because they were looking at, well, if we stop the Tamsulosin a week or two before the operation, is this going to mean that their iris will then dilate when we try to dilate it in the operation? And it didn't happen for a lot of them. And it sort of makes sense when you think about the iris as a muscle, because if you've been taking Tamsulosin for 5 years and your iris is like a muscle, like any other muscle in your body, and it's just been relaxed and sitting on the couch for 5 years, then it can't constrict because it's not primed, it's not ready to go. It's like a wimpling. So interesting.
It's really maybe a better example of the SSRI type paper where I just threw it in for interest. I would love to write floppy iris syndrome on somebody's chart. Maybe you sound smart at a party sometime when somebody says this, because I always hate it as a doctor when somebody brings up a medical condition and I have no idea what the hell it is. I feel like we're supposed to know what diseases exist out there, but I don't think there's really any clinical import, especially because, as you say, the stopping the Tamsulosin doesn't seem to help, and sending somebody into urinary retention 2 days before they're supposed to have an operation also doesn't necessarily help them. So the only thing that I could possibly come up with as a reason that this might matter to me would be if somebody out there treats kidney stones with Flomax still, and they're going for surgery in 3 days, maybe don't for that patient, but that's really stretching it. I don't think there's any clinical import. I just thought it was an interesting name syndrome that people might want to hear about. That's all it is.
I I can think of one emergency department relevant part of this is that whenever we see a patient with an eye problem, I just put an ultrasound on and have a look in their eye. But when you call the ophthalmologist, they always say, "Oh, have you dilated the pupil to have a look?" And now I have an excuse for why I didn't dilate the pupil. They're on Tamsulos and I can't dilate the pupil. Sorry, mate, it's a no-go. Floppy eye syndrome. You're going to name drop that in my next ophthalmological consult. See if they think I'm a total moron. Anyway, cool. All right, let's move on to the next paper then. And this is probably the paper of the month if you're a critical care sort of person and you're really interested. And I think, Justin, you're going to be doing a big deep dive into this paper in the next couple of. Hopefully it's out now and people can go and read your deep thoughts on it. So I'll do a bit of an introduction and then we'll run through the whole trial because it's probably one that I don't think it'll change my practice, but it'll reinforce what I've been doing, which is good. So this is a multi-center Japanese ICU trial. They recruited about 500 patients with who are aged over 65 years and were in ICU because they had septic shock, essentially requiring vasopressors mostly. And the question is, when you have got these patients who we all treat every day in our emergency departments, do we stick for the traditional target map of 65 to 70? So in my place of work, 65 is the magic number. Everyone, we try and keep the map above 65. Or in these older patients that have chronic hypertension and we're worried about maybe their kidneys need a bit more kick or their carotids are a bit tight, should we be aiming at 80 to 85 as a map? And this was a pretty well done trial, multi-center. It's all done in Japan. The background population was sort of patients you'd expect in that age group. Quite a lot of chronic comorbidities and hypertension. About half of them are on treatment for hypertension. And the bottom line was that if you tried to shoot for a higher blood pressure, so if your target was 80 to 85, then mortality seemed to go up and went up quite dramatically if you believe the numbers. So the all-cause mortality at 90 days was nearly 40%, this is a pretty sick cohort, that 40% in the group where they shot for the high pressure and just under 30% in the group that went for the sort of traditional 65. So an absolute risk of death is about 10%, or as we like to say, the number needed to kill was around 9 or 10. So it was certainly not something that I'll be changing my practice around because this paper, if you believe it, certainly suggests that there is no benefit and potentially a lot of harm in shooting for a higher map target in septic shock patients. Now, Justin, there's a few problems with this paper and I'm going to let you dive into it because that's what you do really well. So my question for you, though, is what killed these patients, these extra 10%? Because I could not work it out from reading the trial. I've got a few theories.
This paper is interesting. When we talk critical appraisal, I think one of the most important steps of critical appraisal is forget about the methodology and just take a step back and does this pass the sniff test? Or what are your initial instincts? And I went both ways as I read this paper, and I still sort of jump back and forth. So there's the one side of you, which this is pretty obvious. Every time we have decades of research now, when we try to treat the number and not the patient, when we do these aggressive, whether it's tight glucose control or whatever it is in the ICU, we hurt patients. So the fact that we might hurt patients with a more aggressive number-based approach doesn't surprise me at all. That being said, we try to change mortality constantly in the ICU in modern medicine, and we're amazed when we can do a 1% change in mortality here or there. Changing a blood pressure target by 10, I'm going to kill 1 in 10 patients. That's just sort of unbelievable right off the bat. There's just no way, especially when you take a look back and the actual blood pressures between the groups were pretty close throughout the trial. There was a difference, but they were mostly the same. Yep. There's just no bloody way that 1 in 10 patients was dying because of what they were doing in this trial, or because of the blood pressure thing. So it doesn't really pass the sniff test, even though I actually sort of believe the results that being aggressive would cause harm. So I don't know what that means. I'm going both ways. The big problem with the trial is that it's a open label trial, right? Unblinded trials are always problematic. Sure. Although looking at mortality, that should temper some of that bias in a natural unblinded trial. It's a really tough trial to interpret from all of those standpoints. I think maybe the biggest problem with this trial is just the trial size. Even just based on their power calculation, they thought they powered this trial, which is one of those things in medicine. They thought they were going to see a 10% absolute change in mortality. They thought it was going to go the other way. But to me, that was either overly optimistic or insane. Like I'm trying to find kind words. Like we just don't see those kind of changes. And when you have a trial that is too small, it's quite possible that this is just the random standard deviation statistics going over time. So I don't know. There's a lot of issues that make me wonder about this trial. But at the end of the day, it sort of doesn't matter. The harm goes in the harm goes in the direction of non-standard care. Standard care being a map of 65. I don't believe that you're killing patients if you go to a map of 75. But there's also no bloody reason to do it. So you can sort of ignore the paper. I wouldn't be overly worried. I think the wrong takeaway would be to say, to see a patient where you're treating, you got them on norepi and their map has gone up to 72 and freak out and back off on the norepi. That would be the wrong takeaway from the trial. I don't think you're killing people, but I think stick with standard of care. Maybe try to find more clinical markers of perfusion rather than focusing on a single number like the map.
Yeah. I think that's what most intensivists do is they don't just look at one number, they look at all the different numbers and try and make a decision about what to do next for the patient. It was an interesting, in terms of the protocol that they followed for this trial. So normally when we treat patients with sepsis, they get a bit of fluid, and over the recent 10 years, that volume of fluid has certainly come down. So if you go back to Rivers, 2000 or whatever it was, we were giving like 7 liters of fluid up front, and nowadays we're giving a few liters. So they did that. They tried to limit the amount of catecholamine based presses that they used by introducing vasopressin earlier. And if you dig into the deep, I don't know if maybe it's just me, but I love reading the supplementary part of the thing. But it wasn't actually written in the paper, but one of the few differences between the two groups, because their blood pressures weren't that different. Like there just wasn't enough separation between the two groups in terms of blood pressure to sort of explain this. Like if you look at the scattergun plot, there's a big overlap between the two. But there was a big difference in the dose of vasopressin that the two groups got. So the higher map target group got 30 odd units in the first 24 or 48 hours or however long they went, whereas the standard group only got like 11 and a half units. So 3 times as much vasopressin. So maybe it's vasopressin that's killing these people, because that's one of the only interventions that was actually different between the two groups. I'm not saying that was the case, but it's certainly interesting that they tried this different protocol and they seem to have killed more people, if you believe the numbers. But like I say, it's mostly going to be just random statistical drift. But they also presented a few of the papers, a few of the numbers in a weird way. They presented it in terms of catecholamine-free days, which is quite interesting because pretty much everyone was off catecholamine like within a couple of days. I think it was five days of presses in the high target group and 3 in the no target group. But they presented it as like in the first month, how many catecholamine days did you have free? That's sort of like a backwards way of thinking about it. Just tell me how many days of catecholamines they got. That would be a better way of presenting it, because you read that stat and you think it doesn't make any sense, but yeah, they're actually quite different when you look at the baseline.
Yeah, I missed the vasopressin difference. I'm not sure how it matters, but there's a lot of debate amongst critical care docs about the role of vasopressin, and some people are doing push dose and some people are doing a lot earlier, and there's some really big believers in vasopressin out there. I have not been a huge user of it, so I haven't been following the literature that close. I was just sort of waiting for it to settle itself out, but that is an interesting hint that might play into some of those arguments in the future. For now, I'll just let the smart critical care docs debate about it, and I'll sit back and listen to them. To date, I don't believe there is a single study ever that shows mortality benefit with any kind of vasopressor. I still don't think we have any idea what the hell we're doing. So I'm pretty happy going back and forth between pure, what we call in North America, norepinephrine and epinephrine. If I think you need more heart squeeze, I'll lean a little bit more towards epi. If I think you need less heart squeeze, I'll use norepi, and I can just sort of balance it out from there for most of my patients.
Yeah, it's critical care has become a lot easier since we've had this sort of nihilistic evidence base that come as a result of sort of the Horizon process and all those big trials sort of 10 or 15 years ago. So it's become a lot easier. We can be nihilistic and just say it doesn't matter what you do as long as you do it carefully. Yeah, cool. All right, let's move on to another headache. As that's for a segue.
Generally, we fail, but I'll give you once a year. Maybe you're okay at leading us into our next paper. Yeah, that's fair. This was an interesting paper. So it's by a Turkish name, Donmez, in the journal Annals of Emergency Medicine. Analgesic and anxiolytic effects of virtual reality and classical music therapy on tension-type headaches, a randomized controlled trial. So good methodology. It's a single-center RCT out of Turkey. They use an NSAID that I have never heard of before. I could probably pronounce it. Dexketoprofenetromethimol. Yeah, sure. I don't know if 25 milligrams is a usual dose, but 25 milligrams IV as the standard treatment versus that plus a VR experience with classical music and some kind of virtual reality. And I really liked it. I actually went and watched their YouTube videos. They use scenery from Canada, of course, because Canada is the most beautiful country in the world. I don't know if the VR makes it better.
Were there people being... Were there people lumberjacking and being attacked by mooses?
Scenery. Although the quality of the video was crap, but maybe the virtual reality, when I watched it on my screen, it wasn't my favorite of all time. Anyway, the idea was, does this VR experience with classical music make you feel better in a tension-type headache as compared to NSAIDs alone in an RCT? Obviously not blinded because you can't blind this kind of thing. And basically the answer was yes, with pretty dramatic numbers. Like the at 2 hours, the control group had moved from basically 80 out of 100 down to 46. So they felt better with NSAIDs, whereas the VR group had moved from 80 down to 12. So the difference between those groups on a 100-point scale was more than 30 or more than 3 out of 10, which is what we would consider clinically significant. And then they measured a bunch of other things. Yeah, patient mood was better between the two groups. Only 3% of the VR group needed rescue meds. 46% of the control group needed a rescue med. So the outcomes are pretty dramatically different between the two groups. So I guess before I say my parts of the critical appraisal, those are big numbers. You buying one of these for your department? You using it on your patients? Using it for yourself after a long flight? What do you think?
Well, we'll just go back to the start about the patients that actually enrolled in this trial. So they had to meet the headache criteria for what's now called chronic daily headaches or tension type headaches. So basically the most vanilla headache that you can possibly have. So it couldn't have any features. Basically it was just what we used to call a stress headache or a tension headache. And they use pretty rigorous criteria. And we see these people a lot in the emergency department. My general treatment of those patients is to tell them to go home and have a nap and take a walk. And if anything, this tells me that they should go walking in a forest maybe, rather than, I don't know that they need to remain in the emergency department to have this intervention. And I think this goes back to the paper that Gerben wrote before. Like if you see this patient at the front of the shop and they're describing a classic sort of tension daily headache, and you order a CT or you even give them any drugs, you've basically probably made them think that there's something going on in their head, which there isn't. And you could just say, hey, you're fine. You go home, this headache will go away. And we've got data now on a randomized controlled trial that, 50-something% of your symptoms will disappear in a couple of hours if you do nothing. Apart from, well, they did get the intravenous non-steroidal, but I'm not really sure that actually does anything for these types of patients, to be honest. Like it's pretty
we get so many mistakes, right? Because like we use intravenous, but I use intravenous in migraines because the patients are vomiting their guts out. But yeah, we know for sure there's no difference between oral and intravenous NSAIDs. There's many studies for that way. So I agree. Like your sentiments are entirely right, because it's not just tests. In the Gerben's paper, we talked a lot about tests, but even just ordering one dose of IV medicines screws up your entire day. Now you got to come back and reassess this patient. Yeah. The amount of nursing time they're taking up a waiting, it takes a lot of extra time for the department when you could just say, take some ibuprofen and have a nap. Like I 100% agree with you that we need just the whole concept of this
walk in a forest.
Even forget the VR technology. Just the IV is a problem. But now you're going to have all these patients coming in for a VR experience in your department. Like, give me a break.
It's you could argue that the anti-therapeutic effect of remaining in the emergency department is probably more detrimental than total placebo, just saying you're fine, get out of here. Because sitting in an emergency department waiting room with a tension or chronic daily headache is probably the worst possible place on the planet that you could be. You've got kids screaming, you've got old people vomiting into buckets. Like, that is not where you want to be. So I think I don't think this will change my practice. I don't think I'm going to start giving these patients non-steroidals. They can take them on their own if they want. But I think this certainly shows us that distraction is probably the therapy of choice for these people. And so if you can get distracted by doing something that's outside of your own headspace, whether that with the virtual reality or actual reality, that's probably the right thing to do. And a bit of coaching is the way to go. The last statistic that I pulled out of this, Justin, that just blew my mind was that I think nearly half of the patients in the placebo or the non-VR group ended up getting fentanyl as a sort of rescue med, like, which is just like, if you're giving fentanyl to these patients, something's gone horribly wrong with your day. Because sure, it'll make them feel better, but it's not the way to go. Maybe I don't understand Turkish pharmacology, but
I think like if you take a step back, this is another, like, on its base, it's really, really hard to have an unblinded headache study because it's subjective outcomes. So that these outcomes sound a little bit too good to be true. Like we compare all the analgesics and we never see a 3-point difference on a 10-point scale in pain. But I believe it, right? We know that distraction's good for pain, and we know tension-type headaches are stress-like, so we have an anti-stress type intervention. So I'm mixed in terms of how much I believe it. But yeah, I think we missed the base entirely. Now, I think it sounds like we're coming down pretty pessimistic on this paper. And actually, when I initially put it in as a write-up, I put it in with a pretty optimistic mindset, not because of this paper in of itself, but as a reminder, I think, of how miserable our emergency departments actually are, and maybe just to think about that. So number one, for the headache patients, the best place for them is not the department your entire life. Their best place is their own home, whatever their comfortable space is. But we could probably take a lesson from that. Because really what we're saying is these patients do better taking them out of whatever the environment it is. I doubt that the VR actually has that much. And we should note, we're very careful so if people are really excited about this, we were very careful to only include tension type headaches. I could imagine a VR headset with somebody with photophobia and a migraine might actually be harmful. So if you took this out into the clinical world, you could actually do some harm. But I think there is something to say about taking a step back. Emergency departments were not custom designed. They came out of a historical practice of just needing a place to let patients come into the department. And can we do better than what we're currently doing? And my guess is we can. And this paper is sort of a hint at that maybe we should try. My department recently instituted a geriatrics zone, with the idea being, for delirium's sake, we want to have a place where the lights are going to go off at night and it's quieter and we're removing them. We've always had a pediatric zone. So the peds patients are well away from our methamphetamine patients and our unhoused population and things like that. Those are things that you can do to improve patient experience for some patients. It doesn't help. I had a poor patient with COPD trying to get to sleep at 3 a.m. last night next to this delirious patient who was just screaming every 3 minutes, and they were sharing a room, and all I could do was shrug to them because that's just how our departments are designed. Somehow this was a new design space in our department and they were still shared rooms or with hallway spaces. So I think in the long run, the status quo bias has led us to have architecturally poor spaces. And if I was sick, I would want to be in a quiet, private room. And I think we can do better for our patients. And so that's where my brain went when I initially did this. And I guess maybe knowing that if I got sick in a month, none of the emergency departments in my city are like that. Maybe I will buy a VR set on the way to the hospital so I can just escape, or maybe I'll just use my own ketamine and try to go into my own personal space. I don't know. Escape the world is what you want to do if you're going to an emergency department.
I will say my last point about this paper, Justin, that gave me a headache was that I spent quite a lot of time staring at the little diagram that they had that tried to represent all the patients. So it was a very bizarre looking diagram. And I know this is an audio podcast, but we'll put this up on the blog post that accompanies it. But it essentially looks like a heap of hanging vines one half's red, one half's green. And I spent quite a lot of time looking at going, what on earth, how do I extract information from this?
I thought it was really
bizarre.
pretty, but yeah,
it's like not a forest
it's
plot,
not so
like
scientific.
A rainforest.
It's very, very pretty. Before we go to the next paper,
when I first saw it, I thought it was...
Oh, yeah. Go ahead.
Oh, sorry, when I first saw it... When I first saw it, I thought it was actually a picture from the Forest VR. That's what I thought it was. So thank you.
I'll apologize to you as you edit this podcast and to any of our listeners. I'm realizing as I'm holding this, I might have for a portion of this podcast turned the microphone around. So I might have been talking to the back of the microphone for a little bit. So I hope I didn't ruin our entire audio, but we'll see. If I got really quiet, audience, that was entirely my fault because my microphone snapped literally 10 seconds before we started recording. So we'll see how this all goes.
Cool. All right. Shall we move on to the next paper, which you don't think is very relevant, but this has caused a lot of headaches.
I think it is really relevant. I mostly put this
intro?
in there as an FU to my colleagues and yes, looking directly into the eyes of an anesthetic colleague right there. We'll see. Because anecdotally, after Ozempic and all of these GLP-1 antagonists out, the anesthesia colleagues are telling you that it delays gastric output, and this is going to be a disaster. All the idea of NPO rules, and there's story after story after story of that being the case. And the reason this has become a bit of a headache for me is that I've been on a bit of a push around emergency departments for a while. And I think we talked about this a little bit before about how silly our emergency department NPO rules are. We keep all these patients fasted. And I had sort of made a little bit of headway, and the anesthesiologists were like, yeah, I agree. The guidelines are saying that 2 hours is pretty reasonable. And yeah, people can drink some water like right up until the moment of surgery. Everybody's on that board. But then they said, no, but now modern practice is going to completely change because everybody's on Ozempic. And so we have to completely go back to being everybody fasted for 24 hours or something along those lines. So that's this paper. I have a bit of an axe to grind with it, but it is the first bit of data that I've actually seen on the topic. And I do think that these conversations should be data based, even though it's important to be patient safety. So what this actually is, I can probably tell you, it was in JAMA Network Open Chen. Postoperative aspiration pneumonia among adults using a GLP-1 receptor agonist. And it's a massive data dredge as we are want to use American private insurance database. So it means we have a lot of patients, 360,000 more than patients. And all of them had some kind of, there was a list of, I think, 14 common surgical procedures. They looked at anyone getting the procedure. And then the comparison was anybody who had in the 30 days before been taking one of the many GLP-1 agonists that are available out there compared to those who weren't. And the outcome of interest was 30 days after that, did you get an aspiration pneumonia? Now, obviously, this is a chart review. Lots of reasons to think that aspiration pneumonia might not be documented properly. Lots of reasons to think that your prescription rates might not be documented, although this was the person paying for both the surgery and for the expensive drugs. So I think we can probably trust that data point, at least to some extent. And a little bit.
Maybe come to that.
In American practices and expensive drugs, this person probably does have data on whether you got surgery and whether you were on the drugs, at least a little bit, I would expect, but we'll see. And the rate of aspiration pneumonia was actually, statistically unchanged. Odds ratio was 0.78, so it was actually lower in the GLP agonist group. I would have been worried if it was the other way, if it was a little bit higher, just not statistically so. That's one of those things, but it was actually lower. And when you look through, like the big thing is like, this is crap data, right? The crap data. The patients are completely unlike each other, and I think this is the point where I think your clinical input is going to be interesting. But when I look through the groups, I actually think that at baseline, the people on Ozempic or et cetera would be higher risk. Like they have more diabetes, more obesity, they're older, they had more bariatric surgery being done. Like that to me sounds like the aspiration risk group, and they actually had lower rates of aspiration pneumonia. So, I mean, this is not data that we should be hanging our hat on by any means, but it's the first data out there, and I do sort of hang it up there as being like, hey, let's not overreact just because somebody's on Ozempic. Doesn't mean that we should absolutely completely change our fasting rules or change rules otherwise. But I was really interested when I included it to hear an anesthesiology perspective, even if I decide to make fun of you in 5 minutes. So go ahead and tell me what your take was.
Oh no. I can speak from the Australian anaesthesia sort of point of view in that when Ozempic and all these drugs came on the market, the people that write guidelines in the anaesthesia world lost their shit essentially. I think is the polite way of saying it. And so when the first round of guidelines came out after these drugs hit the market, the pre-op sort of preparation of these patients was crazy. So these patients were being told to stop their GLP-1 inhibitor sort of 3 weeks or even longer beforehand. So they were sometimes going months without these drugs because some of them were like a once weekly injection. So some of them were missing like weeks and weeks of therapy. And then they were being told to fast for solid food for like a week and only have clear fluids and then have 24 hours of absolute fasting prior to the actual
starved,
procedure. So,
dehydrated patients. It's really good.
Onerous.
Never any complications, never any renal outcomes, never any perioperative hypotension when you have absolutely starved, dehydrated patients coming in to have major surgery. Sure.
It was absolutely horrible. And so we, in our pre-anesthesia clinic, so I normally see the patients that I'm anesthetizing the day prior to their procedure. And sometimes when we have a sickie or someone's got a lot of comorbidities, we might see them like a week prior just to make sure all their meds are sort of up to date and see if there's anything we can optimize about their care before they come in. But we were seeing these patients like a month or two out beforehand to sort of try and counsel them about this horrible fasting regime and do you really want to stop your meds? And it was just horrible. We were making a lot of enemies. But the college has flip-flopped a few times on this. And so now we're basically back to, they just keep taking the drugs and you take a careful history and consider cancelling them if you're worried about reflux or indigestion or anything like that. I'm actually teaching at a workshop next weekend where we're going to be teaching gastric ultrasound.
I should have bet. I should have put money down that gastric ultrasound was going to come out of your mouth. Yeah.
But I guess in the old days we used to worry about fasting times, and I always argued that you're better off knowing is the stomach got anything in it rather than how long is it since the patient ate. But even that question, is there something in the patient's stomach, doesn't necessarily translate to aspiration risk because there's so many other factors that go into it. That neuroendocrine loop, what their lower esophageal sphincter is doing, what sort of surgery they're having.
Yeah, it assumes that you can only vomit from the stomach as well. But everybody has seen bile come out of a patient. We know that the small intestine can also regurgitate backwards if you get to it. I don't know. I think the gastric ultrasound is a reasonable theory, but I would like to see some clinical data that it actually helps before we put too much stock in it because the problem is it's going to be really hard to gather because the truth is aspiration is incredibly rare, but when it happens, it's a really, really, really bad situation when it's a true airway situation. And so it is a very, very difficult scientific question to ask. And it's reasonable to be cautious, but also, if something's happening 1 in 10,000 patients, which is about the number that you see in all the things, changing your entire practice for every other patient, especially the idea of starving patients for a week for that 1 in 10,000 risk, that feels like you're going to do more harm than good. But I'm not saying it's easy because you're never going to get really good data.
Let me stop you there. You're thinking like an emergency physician, doctor. You need to think more like an anaesthetist. We change our practice on 1 in a million. Like we are so paranoid about, especially with elective stuff, like emergency cases. You put them off to sleep. You can only play the cards that you're dealt, so you crack on and do it. But these elective procedures where someone's coming in to have their bunions removed or have their gallbladder out, anaesthetists do get very paranoid about very, very marginal risks in this sort of population cohort. But it's not, I think it's that delusion of control that we think that we've got control over those risks, because if you're moving from 1 in 10,000 to 1.2 in 10,000,
and not just that, the mistake that anesthesia seems to be making here, because I think it's really reasonable to consider the risk, but you got to consider both sides of the coin. You would have to be insane to think that you were doing more good than harm by telling people not to eat for a week for less than 1 in 10,000. Like, who could have gone through medical school and thought that was a good, more benefit than harm? Are you insane? Like, this is the problem. So yes, I think it's reasonable. It's if you're doing something relatively elective, although if they're going to get the surgery anyway, delaying surgery that a doctor thinks is important is actually a harm in and of itself as well. So I think you have to be careful, but it's important. Take every chance you have to make it as safe as possible, but you got to consider the harms of your actions. And I don't think we're doing that in medicine. it's an omission commission problem, but we really need to consider both sides of the coins here, and I think we've gone a little bit crazy in most areas of the world.
Yeah. I think my practice on this at the moment is people that are taking these medications, if I'm seeing them in the pre-anesthetic clinic, like all other things that I do in my pre-anesthetic clinic, I'm assessing risk. And I ask the patient, is this something that you've experienced? Because most patients that get this complication, they can tell you that it's horrible and they end up in the emergency department vomiting. If they've had that, then that's sort of the one patient that I'm going to target and say, well, maybe you're someone that we're going to put a nasogastric down and do a gastric ultrasound before we start. So go all out on that person. But this is still a pretty rare complication. I do want to tell you one anecdote though, Justin. I know this is a 360,000 patient trial, but I've got
100% overrule the data. Yeah,
one of my colleagues, fantastic nurse that I work with, had to come in for an operation, and I got the short straw and had to be her anaesthetist, and she, in a letter from a general practitioner, she was on one of these injectable GLP-1 inhibitors. And this was in the middle of this sort of, knickers in a twist sort of moment from the college where the guidelines said you had to stop it months in advance and fast for a week and all that sort of stuff. And so I had to break the bad news to her that she was going to have to do this. And she said, oh no, don't worry about it. I've just been buying this stuff and I've been stockpiling it in my fridge and on-selling it to other people at a markup. So I haven't actually taken it for 6 months.
That is genius. She's not going to be a nurse for long. That is how you retire fast. That is.
So I wonder how many of these patients in this American database were getting it from their insurer and then on-selling it to their fat neighbor for maybe a slight markup.
I don't think that most people are that smart, and I'm not just judging Americans here. Sorry for American listeners. I think you hit a 1 in a million brilliant nurse there. But also, I understand that there is a demand for this product, but it's expensive at baseline. Who the hell who is she selling to? Like I can understand if you're in LA and you're selling to celebrities, fine, but who the heck is a normal person can afford this without insurance? I don't know. Maybe I'm in the wrong profession.
Well, this is actually covered by our government.
Not if you sell it on, though.
Indications in Australia, so there you go.
The black market is. I guess if she's getting it for free and selling it for $15 or whatever. Okay, all right, maybe I'm honest. She's ripping off the government. So what we're uncovering on air in public is massive government insurance fraud. It's good. We should turn to true crime podcasts, make a lot more money than we do. So maybe we should become a medical true crime podcast.
I'm not going to name any names. All right, shall we move on to our final paper for the day? So this is I think I actually sent you this paper.
I could not believe that I had never seen this paper before. I don't know how I missed it.
No, I read it and I thought this is a paper that Justin needs to read because it's from the BMJ in 2000. So this definitely fits in our old school sort of group. And this paper is entitled Comparing Apples and Oranges, a Randomized Prospective Study. The lead author is, I think, Barone. And this is, I think, the Christmas edition because it was published in December 2000. So the BMJ do have a fantastic Christmas edition where they publish all sorts of nonsense. So definitely worth a read if you get a chance. So essentially what these authors have done is they've taken some apples and some oranges and they've looked at the characteristics of these two fruits and tried to see if they could determine the difference between apples and oranges.
I don't think you're giving it credit. I think,
sort of
I think you got a quote straight from the paper. So the paper starts a quote. For many years, the comparisons of apples and oranges was thought to be impossible. Many authors use the analogy of the putative inability to compare apples and oranges as a means of scornfully reviewing the work of others. Our laboratory has been interested in this problem for many years. We have attempted numerous pilot studies, unpublished data, but have not accomplished a true comparison until now. At last, a successful comparison of apples and oranges has been achieved and is the subject of this report. This is very, very good. 6 delicious apples, 6 navel oranges. They compared them using tools such as a tape measure, a scale, and a liquor scale from 1 kind of sweet to 4 really very sweet. And they could not find any statistical differences except for on one category. So they were about the same size, they were about the same weight, but the involvement of quote Johnny Applespeed is the only statistical difference between the apples and oranges. So I actually think, and we have to end with their conclusion. So their inclusion, not at all full of themselves. This article, certain to become a classic in the field, clearly demonstrates that apples and oranges are not only comparable, indeed they are quite similar. The admonition, let's not compare apples and oranges, should be replaced immediately with a more appropriate expression, such as, let's not compare walnuts and elephants, or let's not compare tumor necrosis factors and linguini. And that is how they end their paper. so good.
I think you need to read this paper, but you need to get like a upper class British AI to sort of do it for you, because like John Cleese would be the perfect.
I don't do it justice, but man, it's great. This is the best scientific paper I've ever read.
It's right up there. So if nothing else, it's coming up towards the end of the year. Get yourself a subscription to the BMJ just for December, just to have a read of this amazing stuff that comes out of the amazing.
And I don't think we should do it, but
all right,
I actually think you could have this paper as a journal club paper and really discuss how did they not find a statistical difference between apples and oranges. Like there's a scientific discussion you can have about true methodology here, and that will actually help learners understand some of the things that we do all the time. But it ain't for now. I think we just got to end with the ridiculous quote, and that was a good month. I don't know how long we are. We're out of practice. Hey, we're in our standard way over an hour. Rambling on about SSRIs and cancer and floppy iris syndrome. We did a good job, I think. I appreciate it. I'm glad you had me back.
Yeah, I definitely learned a thing or two. Thank you very much for bringing all the information, and hopefully it won't be another 6 months till our next episode, but we'll be back on track at some point. And if you would like to suggest any papers to Justin, please feel free to email him or hit him on the comments on the YouTube channel, because he loves reading the comments on YouTube. That's pretty much what he does for a living, as far as I can tell.
I mean, it is unfortunately going to be busy, so I can't promise we're going to keep it monthly. But I do one of the things that drives me to read more than anything else is listeners or paper suggestions by the audience out there, because once it's been suggested, or especially if I can have a debate or an argument about a paper, I'm a little bit more driven to get to work and do it. So I would really love more involvement from the audience. So hit up either the BroomeDocs website or First NEM or the YouTube channel. And if you have papers that you saw that you think people are getting wrong, or that you just had questions about, leave them for us, because we might just get to them and talk about them at some point in the next year.
At some point. And don't worry if you don't think it's a very high quality paper, because if we've proven nothing else tonight, we will tackle anything
actually,
on this podcast.
You're more likely to get on if you find me another floppy iris syndrome is what it is. Yeah.
All right. It's going to go and refresh my subscription to Cell.
Probably a bigger journal than either of us will ever be published in. So we make fun.
This is true.
Pleasure, man. It was good talking to you. We'll see you again soon.